Alright, this is a lecture of male genital system pathology. Starting off here, we're going to be talking about Hypospadias. So, Hypospadias is basically, the way you can think of it, is if you have a penis, here's a penis, and normally you got the hole right here on the end, and that's good. Sometimes though, if you have hypospadias, the hole is going to be down here somewhere, and it could be, various locations, but essentially just means hypo, you think low, and spadias is the hole, so the P comes out here, so the structures there failed to close. If I were to take a cut like this and look at it like this, you'd see there was this spongious material here, and this would be where the urine traveled, and these are supposed to kind of come down and sort of fuse together, but sometimes that fails to happen, and so this is open here and the urine comes out. So that's hypospadias. And so then obviously it's like, first let's back up, this is there were urethral folds is what fails to close there, but epispadias is what's happening up here. And epi, thinking above, as opposed to hypo being below. And epispadias is the opening of the urethra on the superior side of the penis. So it'd be like up here somewhere, right? So P would come out this way, travel down, and go out somewhere over here, okay? And that is due to abnormal positioning of the genital tubercle. So there's something called the genital tubercle, and sometimes that has an abnormal position and results in this condition. And this is also associated with bladder exstrophy. So basically, if you got the bladder like right here, and sometimes the bladder can be really close to the opening here, and there'll actually be the hole right there where like the bladder will come out that way. So this condition is associated with that, bladder exstrophy. Okay, next condition here is like as Condyloma acuminatum, and these are warts. Okay, so you can get warts at different places in your body. If you get them on your genitals, they call it Condyloma acuminatum. And there are different types of things that cause this, but generally, with a human papilloma virus or HPV, there's all these different strains. The ones we're thinking of causing Condyloma acuminatum are strains 6 and 11, okay? So maybe what you could think of is, let's see, that kind of looks like a testicle and a scrotal sac. To help you remember the 6. And then the 11, that kind of looks like the shaft of a penis, okay? So remember 6 and 11 for getting warts, genital warts, or Condyloma acuminatum. And the word they really like to use there is the coilocytic change. And I probably should show you really quickly what that looks like. Coilocytic, coilocytes, I'll just type that in. So these are pictures of coilocytes as it's loading there, and you see they're kind of abnormal looking cells. Here's some more pictures of coilocytes. Pretty clear though compared to ordinary cells. See the ordinary cells around them, and then you've got these ones with the really dark nucleus and lots of white cytoplasm, clear cytoplasm, and that's kind of a giveaway for that condition. Okay, next is Lymphogranuloma venereum. And so essentially what's happening this is a person got a sexually transmitted infection called chlamydia trachomatis, and chlamydia is spelled sort of weird, CHLAMYDIA, chlamydia trachomatis. I'm not going to spell the second word. And there's particularly there's serotypes 1 through 3, L1 through L3. I'm talking about the lumbar there. This is serotypes. And what lymphogranuloma venereum is necrotizing granulomatous inflammation of the inguinal lymphatics and lymph nodes. So you have these lymph nodes. Here's a person's waist, and you've got all these lymph nodes in here. There's their genitals, and you essentially will get granulomatous inflammation. So these lymph nodes here are going to get inflamed with this granulomatous necrotizing inflammation. And it's the chlamydia trachomatis serotypes 1 through 3 that causes this. Eventually, this is going to heal, but a lot of time when you get healing like this, you're going to get some residual fibrosis. And if there is perianal involvement, it may result in a rectal stricture, which means, so here's a person's rear, and this is their anus, and if somehow the necrotizing granulomatous inflammation involves around this anus opening, that can kind of fibrose as it heals, and the person will have difficulty then making stool come out because there'll be this stricture there. Next condition we're talking about here is squamous cell carcinoma. So squamous cell carcinoma, in this case, is the malignant proliferation of squamous cells of penile skin. So we have our penis, and basically we're getting squamous cell carcinoma growing on it. Risk factors, apparently 2/3 of the time, 2/3 of the time, the person who gets squamous cell carcinoma is going to have a history of an HPV infection. Okay, that's a lot. That's a big deal. They've also found an increased association with people who are not circumcised. Although, to be honest with you, I would question that one, because the populations where people normally get HPV are generally populations where the people are not circumcised, so that might have more to do with population than it does with the actual foreskin. But I don't have the data to back that up, so pretend I didn't say that. But it says that the foreskin can act as a nidus for inflammation and irritation if not properly maintained. So basically, if you don't clean it, it can make you sick. Makes sense. Precursor in situ lesions. So there's a couple kind of precursor lesions that can lead up to this. And there's 3 that we're really thinking about here. The first one is Bowen disease. This is not writing very well. Bowen disease. And Bowen disease is in situ carcinoma of the penile shaft, where the scrotum presents as leukoplakia. So you think, basically what's happening here is you've got different parts of the penis, and Bowen is going to be the shaft. I kind of want to just draw out here. So the shaft, this part will be, I'm going to write Bowen on the shaft. I think it's almost like a bow. Okay, so that's on there. And what does it have? Leukoplakia. So it's going to have this kind of white plaque on there. Okay, next is erythroplasia of Curat. Interesting name. Eryth. I'm just going to put eryth because my pen doesn't write very well. Erythroplasia of Curat. My other pen broke on me, so I apologize. I'm using this cheapo one, and it's not very good. This is in situ carcinoma of the glands that presents as erythroplakia. So this one is going to be here on the glands. And the way that to remember this is I'm going to put an E right here. So there's the glands. E for erythroplasia, and it kind of looks like a glands a little bit. See that? And I probably should look up what erythroplakia looks like. I believe it's red colored. For erythro is the term for red. And then the last one is boenoid papulosis. This is in situ carcinoma that presents as multiple reddish papules, seen in younger patients in their 40s, relative to Bowen disease and erythroplasia of Curat. So the other one's usually older people, and that one does not involve in stuff. So basically, then you get these little papules on here, and that one's kind of obvious because it's boenoid papulosis. But just know that one's not as big a deal. It happens to people that are younger. So hopefully that was helpful. Now we're moving on to some conditions of the testicle. First of all, we have Cryptorchidism. So Cryptorchidism is basically, you think about the, if this is a scrotum, okay, there's the penis. So normally when a person is developing, these testicles will descend into the sac. And that's good because in order for semen to grow and everything to work properly, they need a certain temperature, and being outside of the body helps them maintain that temperature. But if something goes wrong, then you get something called Cryptorchidism. I kind of think of it as it's hanging out up here in the crypt. Okay, it didn't descend down, so you get an undescended testicle, causing Cryptorchidism. And this usually happens during fetal growth, and it is actually the most common congenital male reproductive abnormality. So out of 100 boys, one of those boys is going to have it. So that's 1%. 1% of boys are going to have Cryptorchidism. And most of the time, it just resolves spontaneously. This thing just pops down there at some point. If it doesn't, you can do something called orchiopexy, and that needs to be performed before 2 years of age. And the reason for that is, I was saying earlier, your sperm and everything needs to grow at a certain temperature. And if it doesn't, if it's too hot all the time, kind of think of irritation and heat, things not growing abnormally, it increases the likelihood of developing a type of testicular cancer called Seminoma, which basically is a Seminoma. Okay, so be careful of that. Next is Orchitis, and this is inflammation of the testicle. Okay, so I don't know why think of this as they use the word orchitis. That's probably got some weird Latin root or something. But testicles kind of look like O's, if you haven't noticed. So that'd be O for orchitis. Itis is inflammation. So it's inflammation of the testicle. And what causes this? Once again, it is our thing we talked about earlier, the chlamydia. So chlamydia is associated with this, chlamydia trachomatis. But this one isn't serotypes L1 through 3. This is serotypes D through K. Oops, that was a mistake. I was getting ahead of myself there. It's serotypes D through K. Teaching my kids their letters. So DK, all right? Think of Donkey Kong, all right? Or I don't know, whatever the heck. Donkey Kong's, he's hanging off buildings, so he must have large testicles. Not that makes any sense, but maybe it'll help you remember this. Often seen in younger adults, like younger kids usually playing Donkey Kong. Increased risk of sterility, which makes sense. You get inflamed testicles. Also, if you think about this, usually younger adults are going to be the ones to get chlamydia. By the way, it's not just chlamydia. Gonorrhea can cause this one as well. And usually gonorrhea and chlamydia kind of go together. So think chlamydia or gonorrhea. And it doesn't affect the person's libido, which is their sexual drive, because this doesn't actually affect the Leydig cells. So it must just affect the Sertoli cells or some of the other cells in there, but it doesn't affect the Leydig cells. And it's the Leydig cells that are the ones that are pumping out the testosterone. Okay? All right, so next is another thing that can cause this is actually E. coli and Pseudomonas infections. Now, just think about this logically. Okay, younger people are usually more promiscuous. So if it's a younger person, they're promiscuous, so what are they going to get? They're going to get STDs, chlamydia and trachomatis. And they're going to get Neisseria gonorrhea. Those are STDs, gonorrhea and chlamydia. If you're an older person, you're probably not as promiscuous, and so you're less likely to get infected with chlamydia or gonorrhea. So what are you going to get infected with that's going to cause your testicles to get all inflamed, to get orchitis? It's going to be E. coli and Pseudomonas infections, okay? So this is for younger people over here, and over here is over here is E. coli and Pseudomonas. Okay, those are the likely culprits in older people. Another thing that can cause this is actually mumps. Mumps virus. You know, you think it swells up the parotid gland. Well, apparently it can also go down and it can inflame the testicles as well and cause orchitis. But typically, this never happens in children less than 10 years old. Okay, so mumps is our other one. But it's got to be people greater than 10 years old. Okay. And our last possible cause of orchitis is autoimmune orchitis. This is basically just granulomas involving the seminiferous tubules. Okay, so if it's autoimmune, you're going to see the granulomas. All right, next condition here is called testicular torsion. So testicular torsion is twisting of the spermatic cord. Thin-walled veins become obstructed, leading to congestion of hemorrhagic infarction. So basically, remember, we have a testicle coming down, and there's the tube that goes out and eventually, you know, goes to the prostate and whatnot, and then goes out to the penis. That's not the tube we're thinking about here. We're thinking about there's other tubes involved in this, namely artery, and there's also venous blood going here. So arteries are hard and they're firm and they don't get kinked off very easily. Okay. However, veins are not very hard. They're really soft, and blood just sort of passively returns back to the heart through them. So it's these veins that we're worried about being kinked off, and these get kinked off, and what happens? Well, we've got blood coming in. However, if this is kinked, the blood cannot go out. Okay, if the blood cannot go out, what's going to happen? Well, this is going to fill full of blood. And this blood is going to become deoxygenated because it's going to use up all the oxygen. And then things are going to start dying in here. You're going to get, so it's going to be like an infarction, sort of like what happens in the heart. And so things start dying. It fills full of blood, and the blood gets old, and whatever these things go, and it just dies. Okay, so you get an infarction of your testicle, and that's not a good deal. So usually it's due to congenital failure of the testes to attach the inner lining of the scrotum. So inside of the scrotum you have this inner lining here, and if this testicle does not attach to that inner lining of the scrotum, then this testicle is going to be able to just sort of swing around and do whatever it wants to do in there, and that's going to cause it to eventually get, these cords are going to get all twisted up, and it's going to cause this kinking. But in normal people, these are attached to each other. It doesn't allow the testicles to spin around in there. So that's kind of why it happens, and it presents in adolescence. And what happens at these adolescents usually is that suddenly, all of a sudden, they're going to have this really bad testicular pain. And there's this reflex called the cremasteric reflex, where you essentially take a little, I can't remember what they call them, those little sticks, they tongue depressant or whatever, and you scrape it along the kid's thigh. And usually what will happen when you do that is that there's this natural response called the cremasteric reflex, and their testicles are going to go, whoa, and they're kind of going to bounce up in the sack, like pull up a little bit. And when you do this in somebody who has this testicular torsion, that's not going to happen, okay? Probably because everything's dead in there. Next condition we're talking about is the varicocele. So a varicocele is a dilation of the spermatic vein due to impaired drainage, okay? So it's not draining very well for whatever reason. Remember, you got your testicle here, and you've got blood coming in, and then you've got blood going out. And somehow this isn't draining so good for whatever reason. And so what's going to happen is that these veins are going to get really big, and they're going to get really kind of just bulbous with lots of blood, and it looks like a bag of worms because they're so full of blood. And the reason for this is actually really interesting. Usually why this happens. So you've got your aorta coming down, and off of your aorta you have these blood vessels that go to the kidneys, okay? And a long time ago, your testicles were up here, okay? And they descended down, okay? But the thing about this that's kind of interesting is that on one side, your testicles get their blood supply from the inferior vena cava, or they drain into the inferior vena cava rather. So I'm actually not even talking about the aorta. I'm talking about the inferior. I'm talking about venous drainage. So there's the aorta, and then next to the aorta you've got the inferior vena cava. Kind of the same sort of thing. Okay. So I apologize here. I was talking about the wrong thing. There we go. Okay, so there we go. Here's the blue inferior vena cava. Anyway, so a long time ago your testicles were up high, and then they descended, and on one side, see how this is kind of off to the left here, or the right, whatever. Anyway, the point here, I'm just going to get to what I'm trying to say. The point is that this condition is associated with left side renal cell carcinoma. Okay, so I think I was actually put just on the other side, but oh well. The point is this: that on your right side it comes right off of the aorta, okay, and goes down to the testicle. But on the left side, it comes off of the renal vein there, okay, and so what happens is if you get some sort of renal cell carcinoma, it can kind of obstruct the blood flow in here, and that's why you get this bag of worms thing. That's why everything kind of gets blocked up like that. And apparently a lot of infertile males that cannot produce the sperm, it's seen pretty common in there. So if you want to kind of get the high yields from this, think bag of worms appearance, think left-sided, okay, think the left renal vein, and then also think that left-sided renal carcinoma is really associated with this, and also think infertility. Okay, next is a hydrocele. So with a hydrocele, what's occurring here is there is a fluid collection within the tunica vaginalis. So if you remember, there's in the testicle, you've got all these layers, okay? One of the layers is the tunica vaginalis. And what happens with this is that a bunch of fluid accumulates, not blood, it's just fluid. Maybe it's blood. I think this is just like lymph. Yeah, this is lymph. So this is just like it's not blood or anything. It's just like kind of like water almost. It's got the mixed bodily fluids in it. So basically, this gets full of fluid, and then your testicle is going to swell up, and it's going to get large. And so that is the hydrocele. And it says the tunica vaginalis is a serous membrane that covers the testicle as well as the internal surface of the scrotum. So it's associated with incomplete closure of the processus vaginalis, leading to communication with peritoneal cavity in infants, or blockage of lymphatic drainage. So in other words, lymphatic drainage got blocked. What's going to happen? Lymph builds up in the testicle, and you get this big hydrocele. They talk about being able to trans-illuminate this thing, and basically, there are some kinds of tumors that you can get, and the tumor is going to be really full of thick things, like maybe a teratoma or something, and you're going to try to shine light through this, and the light's not going to shine through. So you put a light behind the testicle, and nothing comes out the other side over here. But in this one, it's just fluid, and so the light goes right on through, and the testicle is going to kind of glow with this, reddish color when you put light through it. So that's what happens in a hydrocele. Whereas if it was some other sort of tumor, it wouldn't glow. It would be dense and dark because it's full of other tissue that doesn't allow light to pass through. All right, next is talking a little bit about just testicular tumors in general. Just understand that testicular tumors, where are they going to come from? They're going to rise from germ cells or sex cord stroma. There's two things they can come from there. And usually they're firm, they're usually painless, and you try to shine light through them, no light goes through, okay? So these tumors are made out of harder material that is not transparent. Usually they're not biopsied, and the reason for that is if you go into biopsy these things, what's going to happen is you're going to release the contents of the biopsy into the bloodstream, and then you're going to send it throughout the whole body, and maybe the person is going to get metastatic carcinoma and die, and you don't want that to happen. So you don't biopsy these kind of things. The other reason we don't biopsy them is that 95% of the time they're malignant. So there's no reason, it's extremely unlikely for them to not be something malignant anyways. So what we do is you just need to perform a radical orchiectomy, or in other words, cut out the person's testicle, and that'll fix this. So this first one we're talking about here is a germ cell tumor. So germ cell tumor, this is the most common type of testicular tumor. It's 95% of cases. Usually it's going to happen somewhere during the person's most, fertile age. So boys are kind of start becoming fertile, close to puberty, somewhere around 15 to 40 is usually where these people get the fertility. And there are some things that are associated with the risks. Remember earlier we talked about cryptorchidism, where that testicle is stuck up inside their body, and that can actually lead to this condition, a germ cell tumor, but also Klinefelter syndrome. And I think Klinefelter syndrome actually also has an increased risk of cryptorchidism, but I don't remember off the top of my head. Klinefelter syndrome is where, normally girls are XX, boys are XY, and then in Klinefelter syndrome, you get this 2 X's and a Y, and so it's like a boy, but it's like a really womany boy. Womany, but I mean oftentimes they have increased female characteristics, but they'll also be a little taller, that sort of thing. Physical female characteristics, not necessarily mental or anything. I'm not going there. But okay, so this is divided into seminoma and non-seminoma. Okay, so looking at germ cell tumors. Are they from semen or are they not from semen? Okay, 55% of the time they're from semen. And these ones are really responsive to radiotherapy. So if you hit this seminoma with some radio waves, it's going to kill it, okay? It's going to kill it. But if and these also have a really good prognosis because of that. But if it's not a seminoma, then it says 45% of the cases it's not a seminoma, and these ones often metastasize early. In other words, they early on, right when they first get them, they're going to start spreading to other parts of the body, and they're not always very responsive to treatment like radiotherapy or whatever, which is difficult. So it's the semen that really gets killed. Think of semen dies easily, okay? But non-semen, that might live a little while and spread around the body. Okay, so the seminoma is a malignant tumor comprised of large cells with clear cytoplasm, okay? So large cell, and it's got the clear cytoplasm there. That's a seminoma. And you think about it, semen is almost like an egg. And maybe you think of it's it almost looks a little bit like a frog's egg. Maybe I should show you what a picture of these guys looks like. Spelled it wrong. Oops. There we go. So there you see that. These large cells with clear cytoplasm. Try to find some more of these. Yeah, okay. Anyway, hopefully you kind of get the idea there, what a seminoma looks like. Yeah, see that? Okay, so, I guess I wasn't really done with that yet, sorry. So central nuclei forms a homogeneous mass with no hemorrhage or necrosis. So it just makes this big mass of these malignant tumor cells. And it's the most common testicular tumor. Remember, this was the 55%. Resembles ovarian dysgerminoma, so it's similar to what females get. And rarely these things are going to produce something called beta-HCG. It doesn't happen very often, but if you see that, it could be a seminoma. Has a good prognosis, responds to radiotherapy, like I was saying earlier. So if you shock this thing with some radiotherapy, it's going to kill it. Now let's talk about the embryonal carcinoma, okay? So this is another kind of germ cell tumor. And the embryonal carcinoma is a malignant tumor that's comprised of immature, primitive cells that produce glands, okay? So they're immature, they're primitive, and they're making glands. And forms a hemorrhagic mass with necrosis. So this embryonal carcinoma, you think of these kind of like glands, and they're really immature little cells, okay, and it makes this hemorrhagic mass with necrosis. Now remember, the seminoma did not have any hemorrhage or necrosis, but this embryonal carcinoma, this one does form hemorrhagic mass with necrosis, okay? So think of this gland here, almost looks like an egg or something, but it's like, because that's something of the embryo, because it's got this bloody hemorrhage in the middle, okay? So think of it that way. Maybe that'll help. This is aggressive, it spreads hematogously, whatever, through the blood. So if you hit it with chemotherapy, it might just turn into a different type of germ cell tumor, like a teratoma or something like that. So hitting this stuff with radiotherapy, it doesn't always work the same way as it did with the other one. In fact, it sometimes can make things worse. And it's also possible for these ones to have increased HCG, beta-HCG, but also something a little different is this one can also produce increased AFP, alpha-fetoprotein. This is beta human choriogenic gonadotropin or something like that. And this one is alpha-fetoprotein. Okay. So, yeah. Okay, so that's that one. Next is the yolk sac tumor. Okay, so the yolk sac tumor, this is of the also an endodermal sinus tumor. It's a malignant tumor that resembles yolk sac elements. So it's almost like the person's growing yolk sacs in their testicle or whatever. Most common testicular tumor in children. So remember, seminoma was the most common overall, but the yolk sac tumor is the most common in children. And there's something in these ones called Schiller-Duval bodies. And I really think we just need to look these up so you can see what they look like. Oh yeah, there they are. Some people think these kind of look a little bit like a glomerulus, so sometimes they say it's glomerulus-like. Yeah, okay. Kind of see this would be like maybe, but okay. But that's what it looks like. Okay, Schiller-Duval bodies. That's what we're seeing with this. So that's a really important feature of these yolk sac tumors. Okay, so next thing you got here is choriocarcinoma, and oh, sorry, I forgot to say. Let me go back a couple. These yolk sac tumors increase. So I guess I'll draw the picture of the whatever Schiller-Duval body, whatever. The other thing that's increased with these ones is alpha-fetoprotein. Okay, so a little bit of review. What was the one that had possibly elevated HCG but didn't have anything else really possibly elevated? That was the seminoma. Which one was the one that had increased AFP or beta-HCG? And that was the embryonal carcinoma. That could kind of have both possibly elevated. And what about a yolk sac tumor? What's characteristically elevated? That's AFP. AFP is characteristically elevated. So if you put those in order, the seminoma, just beta-HCG maybe, embryonal carcinoma, both maybe, and yolk sac tumor, usually AFP. All right. Next, we're talking about the choriocarcinoma. So the choriocarcinoma is a malignant tumor of syncytia trophoblasts. Okay, so syncytia trophoblasts, think of it this way. So inside, this is where I think about it. So you got the uterus, and when the egg comes down, it's got these trophoblasts on it, and it lands on the side here, and then it starts to make this syncytia. And syncytia is basically where you've got a lot of cells, and the cells start to kind of wear away their cell walls with each other, and they form like one big cell with lots of nuclei in it. Now that's like a syncytia. A respiratory syncytia virus does this. Pox viruses can do this. So these cells, the syncytia trophoblast, is essentially where the syncytia and the trophoblasts are melding together here. That's kind of what I think of when I think of this. So the choriocarcinoma is a tumor of these syncytia trophoblasts and also cytotrophoblasts as well. So it's a lot like, by the way, this thing then forms the placenta, okay? So eventually this will be a big placenta here, and the baby will grow off of that, right? So so it's made out of placenta-like tissue. And in the placenta, though, there are these, the syncytia kind of goes down in these little things they call cilia, but they're not really cilia like on the cell like we think of. It's just like the mixture of here's the mom's tissue, here's baby tissue, here's lots of surface area for interaction between the two. This doesn't make the villi like that. Sorry, not cilia, villi. I apologize. Villi, no villi. Replace cilia with villi. This one spreads throughout the blood early on. That's bad. And this one, what is going to be increased? Well, if you remember, it's the placenta that makes beta-HCG. That's how you can tell if the woman is pregnant. And so the choriocarcinoma is going to have elevated beta-HCG. And then lastly, we have our teratoma. And the teratoma is a tumor that is comprised of mature fetal tissue derived from 2 or 3 embryonic layers. So it's got a lot of different types of tissue in there. It could have mesoderm, ectoderm, endoderm, whatever. Usually this one's going to have, could be alpha-fetoprotein or human chorionic gonadotropin in it. So either one. Remember the other one that could have either one? That was the embryonal, could have either one. So remember the seminoma was just beta-HCG. The choriocarcinoma was just beta-HCG. And the yolk sac tumor was AFP, and now also you're seeing here the teratoma could have either as well, AFP or HCG. All right, and lastly we have our mixed cell germ cell tumor, and those are just mixed between the two, and this is the prognosis based on the worst component of it. So you have different parts of it, but you make the prognosis based off of whatever component it has the worst prognosis. So that's not good. All right, now we're moving on to sex cord-stromal tumors. So what we just covered above, remember earlier on I was saying there's 2 basic kinds. They can be germ cell tumors or they can be sex cord-stromal tumors. So earlier we're talking about germ cell tumors. Now we're talking about sex cord or stromal tumors, okay? So it's a weird word there, but kind of going on what we're talking about here is this. These are tumors that resemble sex cord stromal tumors of the testicle. And these are usually benign. They're not like the other ones, which are usually malignant. So if it's a Leydig cell tumor, it usually is going to produce androgen. Okay, androgen's like testosterone. So if a kid's got something that's pumping out testosterone, what's going to happen? Well, he's going to get all hairy and manly and everything early on. They call that precocious puberty. Might also cause gynecomastia, because if you're producing excess androgens, sometimes the androgens can be converted to estrogens, and a person could end up getting enlarged breasts if it happens in an adult. So children, they'll get lots of facial hair and stuff early on. Adults grow breasts. So there's something though. You think when teenagers start growing pubic hair and all that kind of stuff, that comes with this nasty stench. It's kind of this ranky, yucky stink with precocious puberty. And so one of the key things here is this, they call them ranky crystals. Okay, so those are associated with sex cord-stromal tumors. So the characteristic ranky crystals is what you see. So we should probably look up what those look like so that you could recognize them offhand. So there they are, some ranky crystals. Okay, that's a good picture of some. So you see these ranky crystals, and what do you see ranky crystals in? You see them in sex cord-stromal tumors. Okay, because they cause precocious puberty and make you ranky, like you're stinky. Okay, rank smell. And Sertoli cell tumor is comprised of tubules and is usually clinically silent. So remember, Sertoli cells are like the nurse cells for the sperm. These big ones that kind of, go together like this, and the sperm, they kind of like take care of the sperm, whatever, and the sperm comes out. So their Sertoli cells usually aren't going to really do anything bad for the person, but it'll be made of these tubules. All right, next one here is the lymphoma. So this is the most common cause of testicular mass in males greater than 60 years old. So if you're thinking lymphoma, you're thinking old people, okay? Lymph kind of sounds like limp. So old people eventually become limp, or they have to limp eventually. So think old, limping, okay? Usually they're bilateral, and usually it's going to be diffuse large B cell type, okay? All right, so now moving on from sex cord-stromal tumors, are moving to the prostate. If you remember what the prostate is, the prostate is found in males. The urine, as well as the sperm and whatnot, travel through it and eventually come out of the penis. So if the prostate gets swollen or enlarged or nodular or whatever, hyperplastic, it can kind of pinch off the urine or cause other kinds of problems like that. Also, this prostate can get cancer in it. Prostate cancer is a common thing. Okay, so basically, it's a small round organ. It kind of lies at the base of the bladder. So here's the bladder right here. And circles the urethra. So it goes all the way around the urethra. It is anterior to the rectum. Okay, so it's the rectum's behind it. And that's why you can do a digital exam, which is where you stick your fingers up someone's rectum and you can feel the back part of the prostate there. And what is this made out of? Well, it's full of glands. In fact, when you have an ejaculation, all these glands secrete a bunch of fluid, and this fluid goes into the ejaculatory contents, and it helps you to be able to, the sperm to be able to do the job and make a good environment for the sperm to live in, because it has some stuff that buffers the acid and whatnot. Also, it says that these glands are composed of an inner layer of luminal cells and an outer layer of basal cells. They secrete this alkaline fluid. And these glands and stroma are maintained by androgens. In other words, if you were to cut off someone's testicles, they wouldn't produce, the Leydig cells would no longer be able to produce the testosterone, and the person's glands and stroma in their prostate would atrophy and go away. Okay? Well, at least they'd atrophy. Okay, so what conditions can occur with a person with a prostate? If you have a prostate, well, it can get inflamed, it can get problems. Again, chlamydia and Neisseria gonorrhea. A young person, that's what can make your prostate inflamed, okay? If you're an old person, again, E. coli and Pseudomonas. Those are what does it with old people because they're not sexually active usually. What will happen if you have prostatic problems? Well, remember the pee comes through here. Well, you might not be able to pee because it'd be all inflamed. Itis means inflammation. So, and you could also get a fever and stuff. And if you were to stick your finger up someone's rectum and feel it, it might feel kind of swollen. Like they use the word boggy, and it might hurt too. Ouch! It's inflamed, so it'd be tender. And if a person were to look at some of the secretions that come out of the person's prostate, you'd probably find some white blood cells in there. And you might even find some bacteria that you could culture in there, and you could find out, is it E. coli, is it Pseudomonas, is it chlamydia, is it gonorrhea? All right, so now going to chronic prostatitis. What causes this? Well, this is just basically person's going to have dysuria, they're going to have pelvic or low back pain, and if you're going to look in the prostatic secretions, you're going to see white blood cells, but you're not going to find any cultures, okay? So acute prostatitis is the one that you can actually culture these guys, but chronic is, for some reason, it's still inflamed, but there's no cultures, but there may still be white blood cells. Assuming by now the white blood cells have done their job and killed off the bacteria, but it's still inflamed for some reason. Okay, what about benign prostatic hyperplasia? So benign prostatic hyperplasia, benign means not bad. It's not going to kill you, okay? Prostatic means your prostate, and hyper means high, and plasia, I think, means like tissue, okay? So basically, you have a bunch of growth. Here's your prostate normally, a bunch of growth in your prostate, and it's getting too big, but it's not going to kill you, okay? Sometimes they call this BPH, benign prostatic hyperplasia. It's called BPH because it's a common thing, happens in a lot of people. And what's happening essentially is you get a lot of testosterone going up here and stimulating these tissues, and the stroma and the glands are kind of growing out of control. And there's a particular type of testosterone that's like super testosterone called DHT. Sometimes they call it dihydrotestosterone. And this DHT makes your hair fall out if you're a man, and it also makes your prostate big. And what converts normal testosterone into DHT? Something called 5-alpha reductase. 5-alpha reductase. So a person has lots of 5-alpha reductase, then their testosterone is going to be converted into this DHT, and this DHT is going to possibly give them BPH. And so what part of the prostate grows the most, that we're worried about anyways? So there's different sections, and they've got different names. The section that's right around the urethra, they have this very wonderful name called periurethral. In other words, around the urethra, okay? On the perimeter of the urethra. So it's these periurethral areas that we're worried about, because that's what causes the dysuria, or inability to pee. And some clinical features are going to include you go to pee, and it's really hard to pee. You have to really push hard. And when also you're having problems with stopping the urine stream as well. And other problems are going to be impaired bladder emptying. Means you'll pee off a little bit of the bladder, and then it'll just stop. It's like someone's kinking the hose. Or it may be that just some of it just gets so full that it just dribbles out. So the person's always peeing themselves, sort of, but not like peeing, just sort of dribbling peeing. So because of that, the bladder really has got to get some strong muscles, so it hypertrophies, the smooth muscle hypertrophies, and that increases the risk for bladder diverticula, which are like these little outpouchings of the bladder, like this. So there's some things that are not good associated with this. Now, how are you going to check this? Well, something comes out of the prostate called prostate-specific antigen, and sometimes that can be elevated in these people. But that gets elevated if you poke the prostate. If you do a digital rectal exam, that's going to elevate it, and sometimes other things can elevate it. So, this prostate-specific antigen is made by the prostatic glands, and apparently it liquefies the semen. So how do you treat this? Well, there's something called alpha-1 antagonists like terazosin. And what these do is they go to the smooth muscle here in the prostate, and they essentially relax the smooth muscle, okay? And that allows the pee to travel through there. It also relaxes the vascular smooth muscle, lowering the blood pressure as well. So that's a good effect. So it's an alpha-1 antagonist. You can also get the person 5-alpha reductase inhibitors, and that shuts this off, which means you get less of this, which means you get less of this, okay? So that can work. That can all, but some of the side effects, though, apparently it can... good side effect for men is that your hair may not fall out, but a bad side effect is that you might grow breasts and you might have difficulty having sex. So sexual dysfunction, gynecomastia, are negative effects of taking 5-alpha reductase inhibitors like finasteride. Alright, now we're moving on to prostate adenocarcinoma. This is a malignant proliferation of the prostate glands. Most common cancer in men. Second most common cause of cancer-related death. So sometimes, well, I guess I'll show it this way. So here is a person's rectum. So it's like right there. And it goes up like this, whatever. And here's the prostate. And a person sticks their finger up there. They can feel this backside of the prostate. Here's the penis. And urethra travels down through the middle. Whatever, you get the idea. Okay, so anyway, you stick your finger up and through here, and you can feel the back of the prostate. And it's that back portion there that typically people are going to get the cancer that you can feel. And so the prostate adenocarcinoma is the malignant proliferation of the prostatic glands. Second most common cause of cancer-related death. The first most common one is, oh gosh, I can't remember if it's breast cancer or lung cancer. I think it's breast cancer, but I don't know though. Don't quote me on that. Look that up right now. Google it. Risk factors include age, race, African Americans, Caucasians. So African Americans get this the most often. Then Caucasians get it second most often. And then Asians. And it's usually from diets that are high in saturated fats. And normally it is pretty clinically silent. It arises in the peripheral posterior region, which is the region I showed you there. And so it doesn't produce the urinary symptoms, okay? So it's growing right here, and that's not really affecting their urethra over there, a little further to the left. And you should begin doing screening at age 50, looking at the DRE and PSA. I don't remember what DRE stands for. That stands for digital rectal exam. So you start giving people digital rectal exams at the age of 50 and feeling back there, and also checking their PSA. The next thing here is if the PSA is greater than 10, it might be worrisome. I'm trying to pick out any more really important information. There's this Gleason grading system that's based on the architecture alone and not on nuclear atypia. Basically what it is that if there's multiple regions of the tumor assessed, because the architecture varies from area to area, a score of 1 through 5 is assigned for 2 distinct areas and then added to produce a final score of 10. So higher score, the worse prognosis. So you got to learn the Gleason grading system. And remember, it's based off architecture. So a lot of times the cancer here, remember your spine's like right here. So a lot of times this can spread over to the spine, and that's pretty bad. It can cause back pain. You can kind of turn this off by giving a person continuous gonadotropin releasing hormone analog, which inhibits the whole process and shuts it off. Shuts off the anterior pituitary gonadotropin, so the LH and FSH are reduced, which is going to decrease the testosterone because the luteinizing hormone goes to stimulate the Leydig cells to release testosterone. And flutamide acts as a competitive inhibitor at the androgen receptor. And that's pretty much the whole lecture. I hope that was